This week on Quality Digest Live, milk, it does a body good. Until the FDA breaks down your door.
And what's happening with quality in healthcare today? We'll talk to author Mark Graban. All that and more when we come back.
Welcome back to Quality Digest Live for August 12th, 2011. QDL is your weekly look at who and what is making the news in the world of quality. I'm Dirk Ducharme, Editor-in-Chief of Quality Digest. Mike Richman is on vacation, so joining me today is Quality Digest Assistant Editor and Webmaster and Contributor and whatever else we can lay on him, Ryan Day. Ryan, thanks for joining us.
Glad to be here.
Well, our first story today is one written by Patrick Stone. FDA protects us from the terror of unpasteurized milk. And this is actually a topic that interests Ryan quite a bit, and it's I kind of want Ryan to tell us what the story is about.
Well, as Dirk said, this is an article by Patrick Stone, who is actually a former FDA agent and author of the book
Bubblegum Badge.
Bubblegum Badge, an FDA history. But the article deals with the recent raids by the FDA on raw milk producers and sellers, specifically a Rawsome Foods, a health food co-op down in Venice, California, a nearby goat dairy, it's a family goat dairy, and also an Amish dairy of all places.
And actually, I believe we have a video clip here of the part of this raid.
Right. For those that haven't seen the video that's readily available on YouTube, we're not talking about your run-of-the-mill warrant
Serving papers.
No, this is a flak vest on, guns drawn, literally guns drawn, breaking in to these facilities and raiding them with extreme prejudice. And the story deals with all the issues stemming from that, and
actually, there were several
issues with that myself.
I meant. Well, I mean, let me ask you. I mean, I personally, you know, I don't mind a little bit of government intervention in my life. I kind of expect it, as long as it's not over the top. I don't get overly upset about it. You and I have talked. I know your views on government intervention aren't quite as liberal, as easygoing as mine are.
No. Now, in this case, I've got to admit that as a consumer of raw milk myself, I do.
You have an opinion.
I do have an opinion, dog in the fight, so to speak. But when over the top, that's exactly what we're talking about with this issue, is how over the top the raid was, the way it was conducted, and that's what really got me, as well as a lot of other people, to really begin questioning the motives behind the raid and the way it was conducted, and start really looking into the FDA's activities, and as a regulatory agency, you know, the discrepancies and things just really caused a lot of questions.
Well, one of the things that you had pointed out, and I think this is what you said, kind of what you wanted to talk about a little bit, is the problem with something like this is that it raises a whole credibility issue, and not just for companies, for entities like the FDA, but anybody who's involved in quality and safety oversight. It takes a certain amount of buy-in from the people that you're providing oversight on, and when you have stuff like this, the whole credibility gets kind of washed out a bit, right? I mean,
right, and in fact, if only I had a bulleted list.
Hey, strangely enough,
these are a few of the things that, again, taken by themselves, these points might not mean so much, but when you go down the line and add them up, then you really have a credibility issue going. And it started off with the SWAT-style raid on the farm. Why there? Why raw milk producers? To being as the Department of Justice lists over 10,000 deaths from prescription drugs And in the same time period, the Center for Disease Control lists 2 deaths from raw dairy products.
Raw dairy products, okay.
Raw
Not
dairy
necessarily
products.
raw milk, but raw dairy
But
products.
raw dairy products. And we don't see that same extreme prejudice exercised against those companies. Add to that the fact that right now, many of the top officials in the FDA are have a revolving door history between the government agencies, the FDA in particular, and the large corporations that they are in charge of regulating.
So in other words, somebody worked in industry, pharma or food or large ag. They come into the FDA. When they leave the FDA, they probably go back into pharma, ag, so forth. So it's the same group of people with kind of a vested interest. But these, I would argue, these people are also probably the most knowledgeable about this industry as well. So I mean, I guess we shouldn't be too surprised that they're part of the same group.
No, but
that doesn't work for you anyway. Okay.
Maybe I am just a grease monkey, but it smells like conflict of interest to me.
Okay. Just saying.
I'm just saying.
Just saying. Okay. I love this last one. I love this last one you brought up. The FDA doesn't believe we necessarily have a right to choose what we want to eat. Tell me where that came from.
There's an ongoing lawsuit by the Farm to Consumer Family Legal Defense, or Farm to Consumer Legal Defense Fund, against the FDA. And in the part of the FDA's response,
let's back this up. I do have this. Basically, also is available online. This is from the Northern District of Iowa, Western Division District Court, a case. The plaintiffs are Farm to Consumer Legal Defense Fund, and the defendants are Kathleen Sebelius, Health and Human Services, FDA, so on and so forth. So basically, the Farm to Consumer Legal Defense Fund against the government, essentially, the FDA.
The FDA operates under the auspices of the Human and Health Services.
Okay.
But I think part of their response of the FDA really gives, for me, an insight into the way that they're thinking. Now, granted, it is litigation, but they didn't have to go with this style litigation. They did, and it's just one more straw on the camel's back, so to speak. When the FDA says,
so this is the FDA's response to the plaintiffs' assertion of a fundamental right to their own bodily and physical health, which includes the foods they do and do not choose to consume. The FDA, or the Health and Human Services, says that point is unavailing because the plaintiffs do not have a fundamental right to obtain any food they wish. So it's the government stand that it isn't our right to choose the food that we want to eat. And the problem for you with that is,
if that's not obvious, I don't know what is. That there's a discussion whether Americans have the right to choose the food they want. That's got to be it's a big red flag to me.
Okay.
It's a big red flag.
So all these things. So what you're saying is that all these things together to you contribute to harming the credibility that the FDA has in Europe. And I wouldn't say, I guess by extrapolation, not just the FDA, but anytime anybody has all these little oddball things going on behind the scenes, for you, you're saying this is a sign of, do I trust these guys?
A huge, to me, yes, spells.
And why should we trust the FDA?
Points to a huge, and mild, semi-anarchist that I am, I do believe that the standards are important, especially in the food supply and food production. But when there's what looks to me like a huge conflict of interest, then it's a problem. It undermines the standards. It undermines the agency that administers the regulations, apply, in conjunction with the standards. And I think it really hurts their ability to regulate.
And I guess kind of spinning off of that, and this is interesting because actually Ryan and I are fairly far apart in kind of our opinions on on government and intervention and so forth. But I do say that your research on this and what you've brought up to me is interesting, because it does go much further than. Let's say we happen to be using the FDA as a whipping boy here and as an example, but really this kind of attitude can happen anywhere. And I think one example I give is, obviously we talk a lot about ISO 9000, and when you talk about ISO 9000, you're talking about being audited. So you've got a registrar, you've got above them, you've got an accreditation agency. From the registrar, you've got the auditors, and the whole thing works only if the people who are being audited have some sort of confidence and faith that the audits are fair, that they're being done in good faith, that there's no ulterior motives or conflicts going behind, and that's what makes the whole system work. And in any system, whether it involves mandatory, regulatory rules, or is a volunteer system such as ISO 9000 or any of the other volunteer standards out there, if the people don't trust the system, then the rules that they're trying to uphold aren't going to work.
Problem.
Okay. Well, Ryan, thanks for all the research on that, by the way.
It's been fun.
And by the way, everything that Ryan pointed out, this is not, I got to admit, as much as I thought it was going to, he's dredging up all these left and right wing bloggers. No, this is all these facts are from the CDC, the FDA, and court cases.
And courts.
And court cases. So interesting stuff. Okay. Well, now moving on from quality in food, we're going to move on to quality in healthcare. And with us today, we have Mark Graban via Skype, if I can get my Skype window up here. And hold on one second. There we go. Mark, do we have you?
I think so. Hi, Dirk.
Awesome. Mark Graban is the author of Shingo award-winning book, Lean Hospitals, and he's agreed to join us here today on the show to talk about quality in healthcare and what is going on with healthcare quality today, and how quality consultants and quality professionals such as Mark, what they're doing behind the scenes in healthcare to make the process work better. Not only, Mark, correct me if I'm wrong, this isn't not only administratively, but also the actual patient care itself. Is that right?
Yeah, that's true. Lean as an improvement methodology is being embraced by people in administrative departments. I mean, a lot of times people might think at looking at materials management within a hospital, applying lean methods there. A lot of hospitals started off looking at their revenue management cycle and saying, if we can send billing out in a less batchy way, we get paid faster. That's worth a lot of money to the hospital. But you also see a lot of improvement in clinical areas. I think lean started to take root in healthcare and hospital laboratories, which to some people's perspective is sort of like a factory. And then it's spread to areas of direct patient care, improving processes in emergency rooms and ICUs, and having impact on things like waiting time, and also preventing infections and reducing mortality.
Now, in a recent article that you wrote, putting the continuous back into healthcare improvement, that you wrote with Dr. Gregory Jacobson, and by doctor we actually mean medical doctor.
Right.
Tell us a little bit about what you covered in that story. You were talking about the use of Kaizen and Kaikaku, I believe.
Right. So as if the word Kaizen wasn't intimidating enough to some people, we throw another word in there sometimes, Kaikaku.
You quality consultants.
Continuous improvement. Kaizen is the word that means continuous improvement in most translations. Kaikaku is a word that means radical improvement. And what Dr. Jacobson and I wrote about, he's an emergency room physician, where they were practicing Kaizen, where he worked at Vanderbilt University Medical Center. Small, daily, low risk, low cost, local improvements. These were not week-long events, and a lot of organizations will call these rapid improvement events, which I think is actually a fairly apt and descriptive term. In a lot of places back in manufacturing, these are called Kaizen events, which is, as we've discussed, it's kind of an oxymoron. It's an episodic improvement project with the start and end point. It's really not at all continuous. And so we were writing about not that events are bad, but let's keep them in perspective, and let's make sure that we're not only trying to do projects and events, that we also have continuous improvement going on a daily basis.
Well, I suppose there's kind of good news, bad news. I mean, I suppose the good news is that healthcare organizations, hospitals and whatnot, are actually trying to embrace these quality techniques, quality methodologies that have been around actually for quite a while and that we're most familiar with in manufacturing. I guess the downside of it is there's still a lot to learn in terms of how to use them properly within that environment.
I think that's fair to say. Healthcare has gone through its waves of improvement programs as other industries have. TQM was quite popular, and it was often quite a big failure in healthcare. People were frustrated that TQM didn't really have the transformational kind of impact you might have hoped. I'm a big fan. Even before I learned about Lean, I learned about Dr. Deming's philosophies. People in healthcare know who Dr. Deming is, and they know his teachings. It just wasn't really, it didn't take root, and that's not Dr. Deming's fault. I think there's leadership issues there. Hospitals have tried Six Sigma. And I think the thing that's different with Lean, some of the leading hospitals out there are really embracing Lean as a management system, as a daily culture, from the CEO down to frontline managers, engaging everybody in improvement. I think that's the difference with Lean, is that it provides a little bit more of a framework for managing, not just doing improvement.
Well, is there anything that's unique about implementing these type of changes within a healthcare environment? And I got to tell you up front, my wife has been a nurse for a long time. She's been a floor nurse. She's been a home health care. She's now a hospice nurse. Mm-hmm. And I mean, I know from her, I mean, I hear her come home at sometimes different agencies she's worked for, and not good words about, the quality. Most of these guys have some sort of quality manager or quality person. And it seems to me like this seems like a more than unusually rough environment to try to make changes in quality using the methodologies that we're familiar with. I mean, is that your understanding?
Yeah, and I don't mean to paint too broad of a brush, but healthcare is traditionally focused on what you might call the technical aspects of work, the clinical elements, your physician training, your nurse training. The problems with quality and patient safety in healthcare are more often due to problems on the process and system side of things. And I think that's where healthcare has just traditionally underinvested in terms of time and resources. A very non-lean factory will still have industrial engineers and process engineers. And the people who are working on the process, it may be built off of very non-lean assumptions, if you will. Hospitals just have a lot of, traditionally have had a lot of very talented, hardworking, caring people, all trying their best. And I think, quality professionals would realize that doesn't work. So when, healthcare professionals get frustrated when they're lectured to do better without being given the time or the methodology or the leadership to try to do so. And, I think that's what we're trying to address with Lean. That's what we're trying to do, what Greg and I are working on together with our company KaiNexus, trying to help bring tools and coaching and methods to, not have this just be, God forbid, any sort of slogans. Again, that's something Dr. Deming would have told us not to do. Not just to have the CEO screaming, we need zero infections. We need to have a method, and we need to have a process for getting there.
Now, in our previous segment, Ryan talked about 10,000 deaths over the past 10 years attributable to prescription drugs. And I'm going to assume that these are probably, without looking into it, I'm going to make an assumption here based on a bit of experience that some of these are due to probably improper administration of drugs, the wrong patient getting the wrong drug, that kind of stuff. When you're working in a hospital environment, do these methodologies like Lean and so forth help address those types of issues that directly affect patient care?
Absolutely. And if you look at instances, for example, where patients in the hospital are giving the wrong medication or the wrong dosage, this can certainly be harmful or fatal. If you look at, for example, the actor Dennis Quaid, his twins were given an adult dose of a blood thinner. His kids were in the neonatal ICU. And what happens is you have just a chain of a progression of errors from the pharmacy, and the check and the double check didn't happen or didn't work properly. Medications got delivered. Now you've got nurses that are often being put under the gun for saying, well, why didn't you double check the medication? Well, the adult dose was never supposed to have been there because it was a neonatal ICU, and multiple nurses across the span of 24 hours all administered that same dose, the wrong dose, and Quaid's twins thankfully survived. There have been other cases where children have died because of this, and a lot of it comes down to process. If you look at the organization of a pharmacy, a lot of times when we start teaching about error proofing in systems, and instead of just saying to everybody, be careful, they start looking and say, well, maybe we shouldn't alphabetize our drugs, because that really increases the risk of grabbing the wrong dose of the wrong medication. Let's put things in a more random order. I saw people do this in factory stock rooms 10 years ago to help prevent grabbing the wrong part of it.
So let me understand the logic of that. I've never heard of that. So the idea was that if they're alphabetical, you might accidentally grab the one beside or in front of or behind, rather than if they were random. If you're looking for something that starts with an A and it's surrounded by a C and a Z, you're probably more likely to pick the right one. Is that the idea?
Right, and that would be an aspect of it. And then you see cases where pills have fallen into the wrong bin. So you might be grabbing from the right bin and kind of doing a check. And this is a human factors issue. When you're not expecting to find a mistake, our brain plays tricks on us. So you may be looking at the med and expecting it to say 5 milligrams when it really says 2 milligrams. And so just trying to help establish the process in a way that makes it harder for errors to occur. And healthcare has relied far too long on asking highly trained people to just be perfectly careful. And the modern patient safety movement, and I think this is where it lines up very well with lean thinking, teaches the simple, I think, obvious point that, look, we're human. Regardless of how much education we have, we make mistakes. We get tired. It might be dark. There might be other human factors involved. We need to have good system design to help prevent those errors.
Gosh.
Okay.
If any industry really needs to get past the slogan phase of lean, root cause analysis,
all those other things,
error proofing,
get past the slogans and down to it,
and really applied, it would be the healthcare industry.
Right.
Right, and tying it back to your first story, I don't recall the government ever coming in with guns drawn to take action against a hospital that was harming patients. I mean,
well, you don't have raw milk there.
You may have a hospital get shut down. When you look at the numbers, and often these are unknowable numbers, but they're on the scale of 100 to 200,000 people dying in the United States due to preventable medical errors in hospitals, preventable hospital-acquired infections. This is the scale of this problem really is
huge.
Really a really big problem.
Well, and actually leads me to my last question before we let you go. So I don't know, what's been happening in the last 15 years? I mean, have we gotten better? Do you think healthcare has improved, or is it status quo? Which way are we moving?
It depends. I mean, right now there are such pockets of excellence within healthcare, it becomes really hard to generalize. Some of these estimates in terms of number of people who were harmed and killed in healthcare were published in 1999 by the Institute of Medicine. They took very conservative estimates and very conservative extrapolations. Health Affairs published an article a couple of months ago that indicated new data is showing that number may have been underestimated by a factor of 2 or 3.
Oops.
So a lot of people are arguing that on the whole, things are not getting better. Now, the good news part of the story is if you look at hospitals like ThedaCare and Virginia Mason, Allegheny Medical Center in Pittsburgh, they've done amazing things in terms of reducing mortality after cardiac surgery. In Allegheny Medical Center in Pittsburgh, they reduced central line bloodstream infections by 95% using lean methods, and they cut mortality 100% because that is a very severe type of infection. You have hospitals doing just great work, but I think the question a lot of us in the quality and lean and patient safety movements ask, why isn't this spreading more quickly? There are, this is not anecdotal data. This is peer-reviewed, medical journal published, really hard, proven data, as much as anything you're ever going to find in the lean improvement world. And it's just kind of a historical pattern. People in healthcare will say a new proven best practice traditionally takes about 20 years to become accepted throughout the industry, and that's a trend and a pattern that goes back 100 years.
Okay. Well, Mark, hey, thanks for joining us and sharing all that information. Again, this has been Mark Graban with us via Skype. Mark is the author of the Shingo Prize-winning book, Lean Hospitals. Well, once again, thank you for joining us for another Friday, and with my buddy here, Ryan Day, while Mike is on vacation. Thanks for joining us for Quality Digest Live, and we will come back to you next Friday, same time. That's 11 a.m. Pacific, for another great show. Thanks for joining us.